welcome to another edition of What's Happening. I'm George Binns, and I'm here with my co-host, Gail Burke. And we're doing our third show on the opioid situation. And we have as our guest tonight the Director of Healthy Gloucester Collaborative, Joan Whitney, and the City of Beverly's Director of Public Health, Bill Burke. Thanks for coming, guys. We appreciate it.
Thank you, George. Thanks for having us.
As I mentioned, this is our third discussion about the opioid. The first one we had was with the Chief of Police of Beverly, John LaLashore, and he mentioned at one time there was a problem that when they would give somebody a dose of Narcan and revive them, somebody who was out cold with an overdose, the person would be revived, and they could get up and walk off and run off and go get another fix or do something. This past summer, the state legislature passed a ruling change that now the police have the authority to put somebody into protective custody, which means you can get them to the hospital, the emergency room, and get them some additional help. And that's where I think we wanted to start the discussion this evening of somebody's OD'd, they've been revived, they show up at the emergency room or the hospital. What happens next? Where do they go from here?
Well, this brings it really to a wonderful point of why we're joining our forces and our resources together across the Cape Ann region and Beverly and Ipswich. It's not one service agency that works independently, it's everyone working together. So the service linkages to help people, when law enforcement or EMS gives nasal Narcan, reverses the overdose, and it has to be opioid related, otherwise Narcan won't have any effect. It's a temporary reversal, so getting them to the emergency department is so critically important. And if anyone's administering nasal Narcan at home, and they've helped a loved one or someone they're with reverse an overdose, please, it's so important that people get to the emergency department because they will go back into the overdose after a period of time, up to about 40 minutes.
The chief mentioned this, that your body's still got the opium or the derivative running around in your bloodstream.
Yes.
And it takes a while for your body to reject it. And once the Narcan wears off, back they go into an OD situation.
Yeah, absolutely. So it's very important. It could be a senior citizen who mistakenly has overdosed by mistaken medications. There's been children who get into medicine cabinets and get into, we don't think of these things, but these are the things that can happen. So please, it's so important to get people to the emergency room. The emergency room will then help to stabilize the individual and help them get into treatment. And this, we're building up the resources and with our education with health providers, helping health providers understand, addiction as a disease, and we've done many together as a region, working with our medical providers and with service providers in all our communities. So from that point, we tried to get people into treatment services and help them get into the right level of care.
So I'm sorry, you made a point in there about it could be somebody at home having. How does somebody get a dose of or treatment of Narcan? It's not in the police department, they're not in the fire department. They go through you, Bill, or?
No, actually, I believe there's standing orders at pharmacies.
Right.
They can either get it through their own provider, or there are some standing orders that pharmacies will order that you can get it.
So that you can have it at home, you mean?
Exactly. And I think Joan brings up a great point is a lot of times when you involve EMS, be it police, fire, ambulance service, they will go to the hospital. But I think, as Joan had mentioned, it is very important, if you do administer it at home and reverse the effects of an overdose, that the person still seek medical help at the emergency room. I think it's important. I think it's important people to know, too, in the same discussion is, there's the Good Samaritan law, there's other things, because unfortunately with some of these ODs that have been fatal, maybe they could have been helped if people made a call, but I think sometimes people may be using with them and they're concerned, so they don't call 911 because they're afraid they face some criminal activity. But the Good Samaritan law, I think, protects them and allows them to help. You know, if they're dealing drugs, that's a different situation, and the police will do what they have to do as police for someone dealing drugs. But if they're just using and they're in an overdose, please, you know, call 911 if someone is in distress for treatment. Don't just, unfortunately, walk away and let them there maybe to die.
Now, you said that it only works on opioids.
That's
so
correct.
if somebody has a heroin overdose, Narcan won't help?
Oh, that's an opioid. So
it is
that
an
would
opioid.
affect.
Okay.
If it's
Okay.
another type of substance, it's not going to
Like what?
reduce. Well, even if someone has an alcohol disorder,
I see, yeah.
it's not going in there and they're unconscious. It's obviously not going to help with that. Or a drug that's not an opioid, it's not going to help with that. It has no negative effects on people, so it's not a dangerous drug from
so
that
if
standpoint.
they give it in that it's not a drug that will be affected by it, it's not going to harm them.
Right. So, for example, I know, like in the fire department, we just got some statistics that while they may administer nasal Narcan because the symptoms look like it's an opioid overdose, it's not. You won't see an effect in all cases. So, when they administer nasal Narcan, and in the last year, it's been a number of times, a little over 100, a little over 60% actually showed a reversal. So that means maybe 60% of those administrations were actually opioid overdoses. The others were not. And whatever it was, the person was unconscious or showing similar symptoms, but it wasn't due to an opioid.
Now, do you work at all with the Recovery High School here in Beverly?
Yes.
You do? Okay,
Yes,
because we
very
don't
much.
really know a whole lot about what goes on at the Recovery High School, how many students or anything like that. How many students do they have?
I'm
Do you
not
know?
sure of their census right now. Bill, do you want to speak to it? Or would you
I
like me
really,
to?
again, it's not. I mean, we collaborate with them on certain issues. Like we collaborate. They're a partner in this in this topic and other topics in the community. So we work with them that way, but not so much with the day-to-day function. I think it fulfills a need. Certainly students, we've had them at some of our regional meetings and presentations to speak about, sharing their stories of addiction. And I think it's helpful too because it's peer-to-peer. I found with seeing the good work Gloucester was doing, and when we reached out for a regional grant, I said, hey, Gloucester's been doing this for quite a while. They got some original pilot grants years ago and had some success. So, we were able to benefit, not have to reinvent the wheel, as Joan mentioned earlier. But, same thing is, when we first got, this grant covers police, fire, school departments, the mayor's office, public health, other organizations such as the YMCA. We all collaborate and all have a piece of this. And certainly, I always found when the police chief would ask me, well, geez, I said, well, talk to you, I could say, well, this is what they're doing in these communities. However, you can talk to your peer, the chief in this community, or the superintendent in that community. And there's a comfort level because they're doing the same job. And in that same manner in the same manner, sometimes to have these students talk to other students is very helpful because, they can identify with one another. And we're taking the big approach on this whole topic is it may be just, not to solve it, but what's causing it, or what may be predetermination, what may, even just helping kids with coping mechanisms. We're looking at things. I just know I have some children that are a little bit older now, just in college or just out. But I just look at kids' schedules nowadays between the academic load and the sports load and the extracurriculars and then everything else is just, I can see them being stressed. And we've heard that through some of the themes, through some of our surveys. The school department and the mayor's task force brought in Chris Herron, I think it was just about a year ago, former Celtic basketball player, born and bred in Massachusetts, and he just talked about his story. And unfortunately, with addiction, it's an equal opportunity destroyer. It doesn't care your race, your sexual orientation, your nationality, how much money you got in the bank. It's blind in every sense of the word.
Well, after you get them through the first phase of drying them out, I guess the more they're an alcohol-related term, but what happens next? What kind of resources are available so that you go to the next step to keep them out of trouble long-term as opposed to get them through the first crisis?
Well, I think what Bill hits on is really important and really addresses your question and why the addiction is a disease, and it's a long-term chronic disease, and really it doesn't choose one person, or everyone is vulnerable, to maybe experiencing addiction in their families and for themselves, or so we really look at the partnership across communities. The Recovery High School is an amazing resource for young people who find themselves in the throes of addiction, and to maintain recovery and to get the support they need. One of the things and disturbing things we see, because as we join as a partnership, we also look at trends and what's happening. And what we saw was that the overdose age range was getting younger, into the young adult ages, which it hadn't been years before. And one of the things that makes us really pull back to say, when it gets to the point where someone has addiction as a disease, at the point of overdosing in your mid-20s, early 30s, that's preceded by probably 10 to 15 years of some kind of substance use going on. So when we say that addiction is a disease, it's a continuum of use. It's not an overnight type of thing you start as a heroin addict. And so we really join as communities to join in partnership, and that's the key word, from prevention of first use, because it's not separate from later complications and drug use. So we really want to raise awareness at young ages. As Bill said, bringing young people in to speak with other people so they can understand, what kinds of things might have led them, if it's lack of coping skills and they wanted to self-medicate or whatever it might be. So we really look at it as a continuum, and whatever we do together, we want to make sure it makes the community stronger and doesn't go away after a grant goes away. Mm-hmm. So, for example, one of the things when we came together in partnership on prevention was prevention of first use was, well, do we have some good information on youth risk behaviors? And so we were able to use some of our grant money early on. A couple of years ago, I think we started making Beverly, helping Beverly have the capacity to have a youth risk behavior survey that now is given, actually this spring. Comes another one. Starting a committee that here in Beverly, which is fabulous, that Bill mentioned, that it works on substance use prevention and brings all the sectors together, police and schools and all the groups that Bill mentioned. The police departments are joining together on crisis intervention team training, and the chief has been fabulous on this, to say what can we do to train our officers so they know how to de-escalate in situations that are either substance use related or mental health related, to help people get into treatment and not be arrested, really divert them from arrest to get into treatment right away. So it's no one thing that works, it's everything together, as a system that really helps people have a common understanding that addiction is a disease, that you need to show support and service linkages throughout the community and pull together on that, and then among communities. So that's what we're just so happy to see.
The thing that concerns me is you were saying that you see it happening to younger and younger people. And, we just recently passed the marijuana, legal marijuana. That concerns me because even though some people say, well, it's not a gateway drug, I think it's the psychological dependence on anything that sometimes leads young people, especially those who have trouble coping, and they need something. And they go for that, and the regulations aren't in place. They really don't know what they're going to do, and it's easy to get. And they start using that, and it makes them feel good. And then they stop using it, they don't feel so good. So they take it more and more, and eventually, who knows? Some of them may go on to worse things like heroin or whatever. And I think that's a terrible thing to have to be confronted with.
There's a lot of education that needs to happen around the effects of the marijuana today, the strength of it, and some of the myths out there. You know, we often hear this in focus groups with young people. They think it's organic. They think it's the healthy choice. What we find from our data is in youth risk behavior surveys, and again, these are perception surveys from young people across communities. Generally speaking, the perception of harm of marijuana is very, very low.
I can understand it because it's in the paper.
Right.
It's legal.
It's legal, yeah.
Yeah.
And this is what we have voted on. Maybe not us,
So-
but I mean, people have voted on that. So it makes it okay.
Well, if we get back to the point you made earlier that addiction doesn't traffic in certain people, ethnic groups, or so
Yeah.
forth. It all comes down to the fundamental. Every one of us has got dopamine receptors in our brain. That's how we feel good about lots of things. And what these drugs are doing is triggering those receptors. So you can trigger them with alcohol, and you remember Gary from the Monday mornings. His brother runs a clinic where most of the people who are drug addicted started out as alcoholics, and they move on. And marijuana is the same thing. It triggers the same receptors in your brain. So that I can imagine very easily the scenario that you're talking about of, well, one joint that felt pretty good, two feels even better. And after a while, well, two doesn't feel as good as it used to. Maybe I go for three. And somebody says, oh, by the way, I got some stuff that's better. And you can just see this escalation going. And I think this is a message that just isn't out there.
Well, that is exactly the message as communities coming together. We're trying to say that prevention of first use is not disconnected from later use. It's very important that we help young people, as Bill was mentioning, find other ways of coping with whatever reasons they may feel it's necessary to go to a substance. There's also the biological sensitivities that, you know, certain DNA, certain families or makeup just chemically might be more sensitive to substances than others. But what we do find, and this is from focus groups, so, you know, themes, that you do generally find early use, and generally it starts with something like alcohol and marijuana that then does progress, you know, can not for all, but for some kids can progress then to pills.
Sure.
And then you go. So it's education all along the way. It's helping to strengthen young people to feel a sense of purpose and confidence and competence in their lives, and help them to make the best decisions they can.
Well, I think that young people today are not allowed to fail. So, especially little ones, they start out in school and everything they do is wonderful. And they're not ever told, no, that's wrong. This is the correct way to do it. And they grow with this sense of everything I do is wonderful. This is great. And they're never told any other way. So when they do absolutely fail, whether it's in school or, I mean, everybody fails at something. When maybe they don't make the team sport that they wanted to. They don't have the coping skills. So I think that has to start at the very beginning. And just, you know, you have to tell children, you're not going to succeed at everything. And you have to understand that. But it's okay. It's good to fail because you learn from that.
There's a phrase that, I do a lot of woodworking, so I'm into that thing. And there's a phrase, the difference between an amateur and a master, the master knows how to fix the mistakes. And I think this is the growth process of getting better is, oh, well, that didn't work right. What are we going to do next time? And you keep working on this thing. The other problem that I see is not only with the young kids who don't recognize the potential for trouble, adults go in for an operation. And I know I had my hip replaced, and they gave me a prescription for 50 oxycodone. And if you use it all, you end up in a situation where, well, I'm not feeling too good. I think I got the flu. It ain't the flu. It's some of the reaction to stopping the pills when you run out of them. And they make it too easy to get, oh, yeah, give them another refill. And next thing you know, you got people who started out with a serious medical problem, treating the pain, and the next thing you know, they're hooked and they're heading for one of your clinics.
And that's a good point, George. And I think part of this whole opioid discussion and by state officials and so forth, there's the prescription monitoring program that was voluntary. I believe it's mandatory now, or soon to be mandatory, where a physician, if he prescribes it, has to enter that in there with the particulars. So, because people, you know, ingenuity, you need it, you have to get it, doctor shop. I'll go talk to Dr. Dr. George, Dr. Gale, and tell them my story, and they might say, "Oh, yeah, that's legit." But before you know it, now this way, doctors can check to say, "Hey, wait a minute, he just got a prescription from Dr. Gale a week ago," and so there's some monitoring that way. Also, I think with the state legislation too, they reduce the amount they can give. You know, I think they give a 15-day instead of a 30-day. With our coalition here, one thing we try to do with outreach was to oral health community, dentists, oral surgeons, because when do you get your wisdom teeth out? College, high school, you know, and you may have gotten a bottle of those, and you know, before I got educated on the subject, you know, we used to say, well, we'll save some of those for, you know, we might need them someday if we had leftovers. And not knowing that sitting in the cabinet, it might not be you, it might not be your spouse, it might not be your children, but it might be people coming into your home that have a problem. I've heard anecdotal stories of people going to real estate open houses for the purpose of going through medicine cabinets to look for drugs. So, I mean...
They'll find a way, won't they?
I mean, it's, if you...
Well, remember, it's a disease that, you know, people find themselves doing things they never thought they would do before. And so really the medical community is so important. Doctors want to learn more. You know, they really want to educate their patients. Dentists, we're working on a pilot right now with Tufts Dental School and helping dentists know how to talk with patients and do some brief interventions with them, talk about alternate pain therapies. So again, it's law enforcement, it's doctors, it's schools, it's faith community, everyone coming together to really get education and awareness out there. I mean, drug disposal, we didn't, I mean, 2008 or so is when we really started even doing something like that. And
that's the reason. At first, as in, you know, in public health, you know, your local health, we're environmental health too. We do, you know, environmental things, odors, pollution, that type of thing. And at first, when we started doing these medical collection programs, I looked at it as more as an environmental health program, not an addiction problem, more like, hey, it's better than flushing it down the toilet and it ends up in the ocean or in your septic system, in the groundwater next to your home. You know, but it was more just for some of those scenarios I mentioned earlier where people are going through medicine care, or people, you know, you're saving it maybe for that rainy day, but technically that's abuse, really. You're not using it for the intended person or the intended purpose it was prescribed for.
But a lot of strides have been taken since in the last 10 years. We now are talking out in the open about opioid addiction, and it's now part of the public conversation, and that's very healthy. And that way people, you know, we try, even though the stigma is still out there, we want to reduce that and say this is a chronic disease. You need medical help. We want to help you. Seek help. You don't have to do it, you know, in the dark, or come out in the sunshine and ask for help, because our providers are there. We're creating these linkages. You know, the high-risk task force that Bill mentioned that's starting here in Beverly, we have one in Gloucester, really helps coordinate care to get people into treatment more seamlessly, because it can be a daunting type of thing, really.
Well, you have a program in Gloucester, the Angel program, and there's been some stuff in the paper about it. How is that actually working?
Well, you know, it's all about trying to send the message of increasing access to treatment, and that's what we're focusing on. So there's, again, a system of programs working together to make it easier for people to seek help and not be frightened. When we began almost 9-10 years ago, people were dying, at home because they were afraid to go to emergency department. They didn't know, like Bill said, there was stigma. They didn't know if they go to jail. Now we know that with things happening to create a better experience for them when they do need either high-risk help or other help, that they will be treated with respect, and they, try to make it as easy as possible. So creating a community conversation and language that it's okay, ask for help, we're here, to help you, is a big part of it, because we don't want people not calling or dying at home when they
And like you said,
to.
sometimes it's just that one window when they're in crisis that they say, hey, maybe this is enough, I need help. If that's tomorrow, things might look a little better and say, geez, I don't think it was as bad as I thought. I'm fine, I don't need help. So I think it's important to have that when, hey, maybe when they're in crisis, they're with their family and, hey, again, and maybe they're just sick and tired of being sick and tired and they want to do something. It's good to have that opportunity.
Absolutely.
It must be frustrating sometimes, though, especially
Very.
when you see the same people coming back and back and back.
Yeah.
And, I think you have to recognize, too, that there are some people that you just can't help.
Well,
You hate to have to admit that, but
Yeah,
I think
yeah.
there are some people that you just have to do something different to get to them,
Yeah.
and I think that's probably what
Maybe,
the process is.
Yeah, and maybe it's just another day that next time maybe they would get it. And there are people out there that you hear talk that, hey, they 3-4 times, and recovery isn't a success story everywhere. Even, I don't say even, but if you look at alcohol, which has been a problem for a long time, and the success rate, people relapse and they get back to it, and they but it is work, and they have to. It's management. You got a disease, you got to treat it. You got to.
And they need the support. So as we're saving lives and getting people into treatment, it's become even more important in the community to have capacity to help people stay in recovery.
Well,
So
we're almost out of time.
okay.
It's hard to believe that a
Okay.
half hour is
But
almost
that's the
gone.
focus
but
right
if
now,
you would
yeah.
like to give, us maybe 30 seconds to finish the program and tell the people, whatever
Where
you
do they
want
go
it
for
is
help?
to
Is
say.
there a number they should call, or
Yeah.
office they should walk into?
Well, we've got
Well, where
so
you're
many.
located.
So if you're talking to Beverly.
Yeah, or maybe just a good generic one. Certainly can always call the health department, and we can take it from there. Again, we're not in the treatment business, so to speak, but certainly we can, someone needs help, we can
You can
assist
give
them.
them a
Point the right
Right,
way.
right.
Yeah.
Can you get a referral from 911?
Well, there's emergency services. So
Can they pick up any information, say, at the senior center?
Yes.
Okay.
Yes.
Okay.
Certainly our office is at the senior center,
Right.
the health department, and information, there's resources.
So we have a number of resources here. Do you want me to share some of these?
Well, we're
Run
almost
short.
out of time, so.
But we have those available at
just
the health
where- yeah,
department, and we
okay.
can certainly make them
Where you
available
can
to you
find
And
them.
folks.
through Leahy Emergency Services.
Okay,
So
okay.
they can do if you're in a 911 crisis
Okay.
and calling emergency services.
How about
for
City Hall? If
evaluation.
they call City Hall, can anybody down there help them, or the school department, or?
Well, depending on the situation, certainly. Maybe certainly the police are a resource, but certainly if it's kind of general or initial and they're looking for information or guidance, certainly have them call the health department,
Okay.
and then we can maybe try to steer them better depending on particulars and so
Okay.
forth.
All right. Thank you very much for coming on the show.
Thank you for
We've
having
enjoyed
us.
it. It's been
Well,
very
thank you.
informative. Wish you both luck, and we'll have to do this again.
Very good.
Thank you
Thank you,
very
Gail.
much.
Thank you.
Unfortunately,
You're welcome.
yeah,
Thank you.
they're
Yeah.
going away.
Thank you very much for watching. I hope that you've all been better informed about what is going on and how to get help if you need to. And we will be back again, and we will do more shows on this very, very important subject. So thank you for watching, and good night.